Let me get started. Thank you, Marty Goldman. Welcome to the last visiting professorship program of the calendar year. It's actually very difficult to get the panel of experts that we have for today's program, and it's always due to an excellent moderator, and it's always due to the fact that we generate, I think, with our visiting professorships, tremendous amount of dynamic discussion about a very interesting topic. And if we go back over the course of the year, the reason I think the program is a success, and not to put any pressure on Dr. Rabinovich, but almost every visiting professor who comes says that this was a unique event, and they really thought that this was a great way of exploring the topic. And a lot of that credit goes to Dr. Fuster, who usually moderates and does a magnificent job, and the occasional time when he gets a respite, and we have our own local experts, like today, Dr. Trivieri, who's going to moderate. But a lot of the credit goes to the fellows. Behind the scenes, the fellows put a tremendous amount of time and effort into the monograph. They spend the half day with the visiting professor. It's usually the first time that I've seen them in a suit and jacket, so it's always very interesting to see what they look like. But it's a lot of pressure. While they're doing other rotations, while they're busy staying up sometimes all night. For instance, Michael around 3 o'clock in the morning sent me the final draft after we spoke about it yesterday afternoon. And it's usually worthy of publication in a prestigious journal, and hopefully all the fellows this year will try to get it finalized. And we're always privileged that the visiting professor has agreed to usually be one of the co-authors. I just wanted to go down just to remind you of the people that we've had and the fellows and the time and effort they put in. Going back to October, genes versus risk factor, predestination versus determination. We had Dr. Christopher Newton-Shea from Mass General, and Tim Hinahara did a really great job on that monograph. In November, Approach and Timing of Advanced Therapy in End-Stage Heart Failure, Dr. Kobishigawa from Transplant Center Cedars-Sinai, and Luke Murphy did a great job putting that together. In January, we had atherosclerosis, early detection and prevention, Dr. Robert Taylor from Emory, Jason Goodman put that monograph together, which was superb. In February, new guidelines for cholesterol, how best to achieve them. Michael Gibson from Beth Israel Deaconess was our visiting professor, and Ben Beer did a magnificent job putting that together. Also in February, coronary disease and diabetes, David Moliterno from Kentucky, and Steve Alexander did a superb job putting that paper together. In March, atrial fibrillation, we happen to have had hot off the press discussion on the Cabana trial with the lead author, Doug Packer, and that was put together by Josh Lambert, who did a great job. In April, inflammation, what is it good for? Absolutely nothing. That was done by Peter Liu, University of Ottawa. Mike Gavalis put a great paper together. And just a few weeks ago, recovery of myocardial function, Dr. Mera from Brigham and Women's, and Mike Healy put that together. Today we have a very daunting task of living up to its predecessors, and Dr. Rabinovich so far has certainly been equal to the task. We'll hear more about her in a few minutes from Dr. Fuster. I just wanted to, as I said before, Dr. Trivieri has graciously agreed to moderate the panel. She's Medical Director of Pulmonary Hypertension Program, Assistant Professor of Cardiology, Heart Failure, and Cardiac Transplantation. Steve Liao, who's Assistant Professor of Medicine, loved by all the fellows, does a great job both heading the nuclear lab, reading radiology, both in echo, MR, and running the CT. mentor to fellows, really physician extraordinaire, is one of the panelists, Barry Love, who we see all the time and teaches really us about pediatrics and cardiology, interventional cardiology. Human Poor, who's assistant professor of pulmonary critical care and sleep medicine, works closely with the heart failure team here. Ali Zaidi, who's a relatively new addition and been really a great addition as system director of Mount Sinai Adult Congenital Heart Disease, director academic affairs for Children's Heart Center, assistant professor, associate professor in internal medicine and pediatrics. With that big lead-in, Michael Hadley, as I said, stayed up to the wee hours of night perfecting the paper. So please give him your attention. Michael.
Hi, everyone. Thank you. So it's my pleasure to just provide a brief overview of today's topic before we dive into our panel discussion. It's a big topic, so my goal here is simply to touch on the key diagnostic and therapeutic options, as well as highlight some of the exciting new therapies under development. So pulmonary hypertension is a pathophysiological disorder involving multiple clinical conditions. Formally, it's defined as the mean pulmonary arterial pressure of 25 or greater is assessed by a right heart catheterization. And many disease states can lead to this elevation in pulmonary artery pressures. Various classification systems for these diseases have been proposed by the WHO, the AHA, the European Society to organize these conditions by pathogenesis and treatment strategy, typically carving up the field into the 5 groups with which we're all familiar. These 5 groups are Group 1, pulmonary arterial hypertension, and a few other disease states with similar pathophysiology. Group 2 is pulmonary hypertension due to left heart disease. Group 3, PH due to lung disease. Group 4, chronic thromboembolic pulmonary hypertension. And Group 5, which is effectively everything else. Left-sided disease is the most common etiology of PH, affecting 60 to 70% of patients with heart failure, including both systolic and diastolic dysfunction. 65% of patients with symptomatic aortic stenosis, and also nearly all patients with symptomatic mitral valve disease. PH due to lung disease is also relatively common owing to high rates of COPD in the general population. Pulmonary arterial hypertension and CTEPH are relatively rare, with an annual incidence of approximately 10 per million and 5 per million in the general population, respectively. And these 5 groups all lead to a final common pathway of right ventricular failure. Initially, the right ventricle adapts to increased afterload by enhancing contractility, and with chronic pressure overload, the right ventricle remodels with concentric hypertrophy with an increased mass to volume ratio that decreases wall tension. When this adaptation is exhausted and contractility can no longer increase to match afterload, maladaptive remodeling takes place with eccentric hypertrophy, progressive right ventricular dilatation, dysynchrony, and maintenance of stroke volume through Frank-Starling mechanisms. And that results in an increased filling pressure and eventually to clinical decompensation. Symptomatology and physical exam findings of PH are mostly explained by this right ventricular dysfunction. Effective management of PH therefore requires early detection and management of right ventricular failure, in addition to treatment of the underlying cause. In terms of diagnostics, echocardiography remains an essential diagnostic tool to evaluate patients for PH. Echo parameters focus largely on RV pressure and volume overload, RV systolic pressure, longitudinal systolic stain, TAPC, right ventricular tissue Doppler velocity, etc. Exercise echo can provide information on right ventricular contractile reserve, which is a good prognostic marker in patients with severe PH. In the future, echo will likely have an increasing role in the early detection and prognostication of PH. In a recent study in JACC, for example, RVSP was found to be an independent predictor of mortality across a cohort of over 150,000 individuals in Australia. And new echocardiographic criteria are also being developed all the time, such as the use of a new TAPC to systolic pulmonary artery pressure ratio as a surrogate for effective RVPA coupling. And despite improvement in our ability to measure these parameters, misdiagnosis by echo still remains prevalent. Cardiac MRI can more accurately measure right ventricular mass, volume, ejection fraction, as well as congenital defects and other etiologies of pulmonary hypertension. Looking into the future, CMR may be useful in identifying RV failure prior to the development of clinical features by evaluating RV fibrosis, metabolism, and perfusion. Exercise testing via a 6-minute walk test or a CPET can also provide prognostic information, as well as formally evaluate patients' functional status and the efficacy of current therapies. Despite the promise for these non-invasive techniques, right heart catheterization remains the gold standard for diagnosis and evaluation of PH. Catheterization permits measurement of pulmonary artery pressures, wedge pressure, cardiac output, transpulmonary gradient, pulmonary vascular resistance, mixed venous O2 sat, and parameters of right ventricular function as well, such as the pulmonary artery pulsatility index. And these parameters enable clinicians to estimate the severity of pulmonary hypertension, as well as the presence of pre- and or post-capillary pulmonary hypertension. Testing with vasodilatory therapy, exercise, and volume challenge during right heart cath can also provide information on the etiology of PH and the potential efficacy of different therapies. So now I just want to review quickly the current thinking on the evaluation and management of the first 4 groups of pulmonary hypertension with a nod to new therapies coming down the pipeline. So PAH, pulmonary arterial hypertension, is a syndrome resulting from restricted flow through the pulmonary arterial circulation due to vasoconstriction and a loss of vascular luminal cross-sectional area due to vascular cell proliferation and remodeling. And this syndrome can be idiopathic, heritable, or associated with a variety of other conditions such as connective tissue disease, HIV, drug exposures, portopulmonary hypertension, schistosomiasis, and congenital heart disease. And I could discuss the pathobiology of PH, such as the function of the BMPR2 receptor, et cetera, but Dr. Rabinovich has already provided a really excellent review of this topic on our noontime lecture. Treatment of PAH follows a tiered process. First, patients are managed with nonspecific therapies like diuretics, anticoagulation, behavioral modification. Patients responding to vasodilatory testing should be tried on calcium channel blockers. And if a patient has moderate severe PH or remains symptomatic or demonstrates abnormal hemodynamics or right ventricular indices, clinicians can consider starting PAH-specific therapies. And there are 3 groups right now of these PAH-specific therapies. The first are the prostacyclin analogs or prostacyclin receptor agonists. Prostacyclin is a potent vasodilator that also inhibits platelet activation and smooth muscle cell proliferation. Flolan or epoprostenol remains the only therapy to show a mortality benefit in PH, but due to its short half-life, it requires constant infusion through a permanent tunneled catheter. Treprostinil and iloprost are other prostacyclin analogs available in oral or inhaled formulations that have demonstrated improvements in exercise capacity and also in hemodynamics. And then selexipag is an oral selective prostacyclin receptor agonist that showed a significant benefit in a composite morbidity mortality endpoint in patients with heritable, idiopathic, or congenital PAH. Next class is the endothelin receptor antagonists, which act by blocking the endothelin A and B receptors, which play a prominent role in vasoconstriction and pulmonary artery smooth muscle cell proliferation. Bosentan, macitentan, and ambrisentan have demonstrated improvements in exercise capacity, functional class, or other composite endpoints. And then the last group of current targeted therapies act on the nitric oxide pathway to facilitate vasodilation and inhibit platelet activation and smooth muscle cell proliferation. Sildenafil, tadalafil, and vardenafil are selective inhibitors of phosphodiesterase 5, which normally inactivates cyclic GMP and its potentiation of the nitric oxide pathway. Additionally, riociguat is a first-in-class soluble guanylate cyclase stimulator, which facilitates the nitric oxide pathway. And all of these drugs have shown improvement in exercise capacity or in hemodynamics. Importantly, though, head-to-head comparisons of different targeted compounds are not available, so the choice of therapy often depends in part on comorbidities, cost, route of administration, safety profile, physician preference, patient preference. And patients with functional class 2 or 3 symptoms may be started on a single agent or also in combination therapy like ambrisentan or tadalafil. Patients at elevated risk at first encounter may need to be started on a combination therapy of up to 3 drugs and potentially intravenous epoprostenol. And for patients with PH from congenital heart disease, both medical and interventional therapies exist. Medically, bosentan, I believe, remains the only targeted PH therapy shown to improve functional status and hemodynamics without worsening arterial oxygen saturation. However, trials with Flolan and other targeted therapies show promising results. Surgical or percutaneous correction of a congenital defect may be considered in patients with prevalent systemic to pulmonary shunting. PAH patients with refractory symptoms should be considered for lung transplantation as well. And if patients have refractory RV failure or Eisenmenger physiology, a heart-lung transplant may be required. An atrial septostomy or pot shunt between the left pulmonary artery and the descending aorta may also be offered as a palliative therapy or as a bridge to transplant as a way to decompress the right heart. Therapy for PAH remains a target of active research. In a recent study published in JACC, investigators tested the development of a vaccine against the endothelin-1 receptor. In the rodent model, the vaccine decreased right ventricular systolic pressure and attenuated remodeling of the right ventricle and pulmonary arterioles. In another rodent model, stem cell therapy as well as BMPR2 gene therapy, both have shown promising results. And over a dozen other compounds are currently under active study. Interventional therapies are also being pursued. For example, a small study of pulmonary artery denervation via radiofrequency ablation catheter demonstrated a significant improvement in pulmonary artery pressures and 6-minute walking distance. Thanks to these targeted therapies, improved detection in specialized treatment centers, the mortality from PAH has improved in recent years. Moving to group 2 quickly, this group is broadly defined as patients with both an increase in PA pressure and wedge pressure. Elevated left-sided pressures are driven largely by elevated right-sided pressures are driven largely by left ventricular dysfunction, mitral and aortic valvular disease being transmitted backward through the pulmonary circulation. In post-capillary pulmonary hypertension, the pulmonary vascular resistance remains normal. And in some cases, however, PVR may increase, creating a transpulmonary gradient and pulmonary pressures disproportionate to the elevation in left-sided pressures. And that's known as the combined pre- and post-capillary pulmonary hypertension, which may or may not be reversible depending on the presence of vascular remodeling as a result of elevated pressures, pulmonary edema, inflammation, and other modulators. Management of group 2 PH begins with standard heart failure therapies to unload the left ventricle, correct any underlying ischemic or valvular disease. That may include the use of mechanical support in late-stage disease. And to date, there still exists no FDA-approved treatments for pulmonary hypertension with left heart disease, but they may be coming. Current trials are evaluating the efficacy of a phosphodiesterase 5 inhibitor and a soluble guanylate cyclase stimulator on HFpEF, and also in heart failure with systolic dysfunction. In group 3, the most common lung diseases associated with PAH are COPD, interstitial lung disease, combined pulmonary fibrosis, and emphysema. Parenchymal lung diseases and or hypoxemia may lead to vasoconstriction, medial hypertrophy, intimal obstructive proliferation of the distal pulmonary artery and arterioles. In emphysema and other fibrotic lung diseases, inflammation and fibrosis may result in destruction of the vascular bed and a subsequent increase in pulmonary vascular resistance. Currently, there's no specific targeted therapy for PH associated with lung diseases. The treatment mostly revolves around treating the underlying lung disease. Patients with hypoxemia should receive long-term oxygen therapy, and treatment with calcium channel blockers or other vasodilators is not usually recommended because it may impair gas exchange due to the inhibition of hypoxemic pulmonary vasoconstriction. And then lastly, group 4, in chronic thromboembolic pulmonary hypertension, the incomplete resolution of an acute pulmonary emboli and potentially local thrombogenesis leads to mechanical obstruction and remodeling of the pulmonary arteries, resulting in a precapillary disease somewhat similar to PAH physiologically. And this disease is rare, but it's also probably underdiagnosed. Currently, pulmonary endarterectomy remains the treatment of choice for CTEPH, although endarterectomy involves a median sternotomy and cardiopulmonary bypass, but it can be fully curative. Medically, anticoagulation, oxygen, and diuretics remain the core of supportive therapy. Targeted therapies may provide added benefit for patients with non-operable CTEPH or persistent PH despite endarterectomy. Riociguat and Flolan have been shown to improve pulmonary vascular resistance and exercise tolerance in an operable CTEPH. Other target therapies are currently under investigation. And the future of CTEPH may be moving to the cath lab. Over the past 5 years, balloon pulmonary angioplasty has demonstrated promising outcomes and safety from centers around the world. However, until standardized training and techniques can be developed, this remains a second-line therapy for patients who have failed to benefit from surgery. Okay, so that's the review. In summary, pulmonary hypertension remains a rapidly growing field. Many new diagnostic techniques and therapies currently under investigation. And in the coming years, we can expect an increasing number of clinical tools to manage these complex patients. Thank you.
Thank you, Michael, your tremendous effort. Certainly is not a simple subject, but this is why we have an expert today, Dr. Marlene Rabinovich, who has a fantastic credentials and curriculum. I will make 8 comments about her and see if we can move rapidly into the discussion. First of all, Dr. Rabinovich obtained her MD degree at McGill University in Montreal. Then she had internship and residency in pediatrics, and this was in the University of Colorado in Denver. Then in 1974, she became a clinical fellow in pediatrics and at the Texas Children's Hospital at Baylor in Houston. And then in 1976, after her clinical fellowship in pediatric cardiology, she decided to have a research fellowship at the Children's Hospital at Harvard. Now, this is about her original education. And now that's said about the academic appointments. Assistant professor at Harvard when she finished her research year, and then associate professor at the University of Toronto, director of cardiovascular research at the Hospital for Sick Children, the Hospital for Sick Children in Toronto. And then was in 2002 when she moved to Stanford, where at the present time she's the Dwight and Vera Dunleavy Professor of Pediatric Cardiology at the Stanford University School of Medicine, Associate Director of Basic Research of the Stanford Cardiovascular Institute, and then Associate Director for Translational Research in the Pediatrics at the Cardiovascular Institute. And she has many titles, but anyway, she has been in all areas of research, particularly basic and translational. And this leads now to a number of major research appointments. She actually had 46 research appointments, national and international, and it's tough to go over all of them, but certainly Canadian Society for Clinical Investigation Executive Counselor, the Chair for Science and Research Advisory Committee of the Medical Research Council in Canada, Chair of the Scientific Review at Heart and Stroke Foundation in Canada, then the American Thoracic Society Pulmonary Circulation Council, American Pediatric Society Executive Council, NHLBI NIH Scientific Advisory Council to the director, and then at the Max Planck Institute for Heart and Lung Research Scientific Advisory Board, NHLBI Lung Repair and Regeneration Consortium External Advisory Board. I only mention this for you to get a feeling of who is here today visiting us as a professor. And now here comes point number 4 about editors. He's associate editor of pediatric research, has been also in circulation research, and she's the editor of actually 13 journals. Now we go into number 5, and that is her credentials in terms of research support. And it's actually amazing. She has had 14 grants from NIH, 14 grants from the Heart and Stroke Foundation in Canada, and 6 grants from the Medical Research Council of Canada. So if you are not impressed, you have a problem. And this leads to number 6, and I'm finishing very quickly, about her research trainees. She has trained 42 people in Toronto, and then 57 people in Stanford, in which she has been in charge, or at least training them, leading the thesis, etc. Now, the question is about awards. This is amazing. And I don't think I can go to all of these, but since the very beginning, wherever she was, she got the best award possible. So this probably summarizes what I wanted to say, but perhaps it's worth mentioning 2004, the AHA Basic Research Prize she obtained, and then in 2006, the American Heart Association Distinguished Scientist Award, and so forth. So the question is, what has been actually her contributions in terms of the science? Well, she started with, you go to the first few papers, certainly started in congenital heart disease and very interested in the pulmonary circulation in Alzheimer's, Eisenmenger's, I'm sorry for that, disease. Then she got more into pulmonary arterial hypertension, but above all, she has been very interested in cell-cell interactions, not only in the pulmonary circulation, but in other arterial systems. And more recently, she has been very involved in terms of the genetic regulation, gene therapy, and so forth, perhaps more focus into pulmonary hypertension. So, a really accomplished person, and we are lucky to have you here today. And let me give you this, at least, plaque for you to remember your visit. It's the last one of the year. We should say it's the best, despite of everything Dr. Goldman said about all the others.
That's too kind of you.
Yeah. Marlene Rabinovich, and he is all the things that we do here, but basically for outstanding teaching, wisdom, and expertise as the Arnandi Sharma visiting professor and the Simon Duck Memorial Lecture. You remember Simon?
Yes.
Very much so. Well, I give you this, and then a check here, not very substantial, but there is a good heart into it. Okay.
That's very
Anyway.
kind of you.
Congratulations.
Thank you very much.
Okay.
I think a picture with my.
Sure.
Picture.
Let's see with.
Oh, there's my card.
Yeah. Okay, thank you.
so much.
So,
That was very kind of you.
this is for
Thank
you. You can sit actually in the middle here. And then we have the panel. First, the moderator, Maria Trivieri. Thank you very much for giving me a rest, and appreciate it. And then we have all the other, I think they are already have been mentioned. Michael, Steve, Barry Love, Humanpour, Ali, you are all here. We have a knee surgeon.
Surgeons, we couldn't find a surgeon because they're busy in the OR.
Okay, all right, good. Okay, good luck to you.
Thank you so much. So first of all, I wanted to thank Dr. Fuster and Dr. Goldman for allowing me to moderate this session. It's really a privilege for me. I wanted to thank Dr. Rabinovich for spending the day with us, sharing her wisdom and knowledge in pulmonary arterial hypertension. And obviously, I wanted to thank Michael for doing such a tremendous job summarizing a complex topic as PAH. And of course, all the other members of the panel. I hope this will be an interactive discussion. Dr. Rabinovich, I've had the opportunity to speak to you earlier, and as I said, it's really an honor for me to have you here, given my interest in pulmonary hypertension. You have truly been one of my role models as a successful clinician scientist, one that has been able to bridge the gap between the basic science and the clinical practice. As Dr. Fuster has mentioned, you have had a tremendous success throughout your career. And I believe that the best way to summarize your work is to define it as a capillary in the field of pulmonary arterial hypertension. I wanted to show slides with, that highlights, not sure it's projecting, some of your more recent work. You have been involved in a number of landmark studies, and your interest in pulmonary arterial hypertension has spanned from the deep phenotyping of the disease with the creation of networks across the United States to the molecular aspect of PAH. And you've used an integrated approach that went from animal model to cell and more recently induced pluripotent stem cell. And I believe that it is because of dedicated scientists like yourself that the landscape of PAH is so dramatically changed over the past 20 years. And we now have more than 20 drugs that we can use, more than 10 drugs, that we can use that targeting the endothelin pathway, the nitric oxide, and the prostacyclin pathway. And all of those drugs have tremendous impact on patient prognosis. But unfortunately, they don't halt the process of vascular arterial remodeling, and most patients continue to experience poor quality of life and prognosis. And despite advancement in basic science, most of the drugs that initially appeared promising in preclinical study don't end up translating into successful therapies and fail to achieve their desired endpoint. So which brings me to the point that a novel paradigm in approaching PAH is desperately needed. And one of the novel directions that you had mentioned and discussed earlier on in your talk today in PAH research is the study of immunopathology, in particular that of innate immunity in PAH. In regard to that, I wanted to just bring the attention of the audience to this study, which you have done looking at the upregulation of a human endogenous retrovirus linked to immunity and inflammation in patients with idiopathic pulmonary arterial hypertension. So my question for you is, do you believe that studying the immunology of PAH might hold the key to explaining the convergence of different phenotypes into a common pathophysiology, which is the pulmonary arterial remodeling? And along the same line, do you believe that the fourth drug that we are likely to be using in pulmonary arterial hypertension would be a modulator of the immune response? You touched upon some of that earlier, some of the work that you have done on that. I really would love to hear your perspective on the topic.
Well, it's an area of active investigation. Yeah. Can everybody hear me now? It's an area of active investigation, not only in our laboratory, but also in the laboratory of many other investigators too.
Right.
And a lot of the new therapies that are emerging are immunomodulatory therapies. So there was a leukotriene inhibitor that was just tested at Imunex. There is also a rituximab trial that indicates some positive results. There's FK506 that's an immunosuppressant, and a new drug called Elephant, which is a recombinant form of an elastase inhibitor that's also an anti-inflammatory. And I think we're going to be seeing more therapies that are really targeting the immune system. The question is, what are we specifically targeting? And that's the challenge. And can we identify biomarkers that are telling us we're actually targeting a mechanism that is highly relevant and not just an epiphenomenon to the disease pathogenesis? So what we think is really important is to understand the myeloid series of cells. So that's incorporating the monocytes that actually are recruited to the perivascular space. That's understanding the antigen-presenting cells, classical dendritic cells, which in our analyses are the ones that are characteristically the most abnormal in the circulation. And third, the neutrophils. Which are underappreciated because they're hit-and-run cells, and it's really hard to, you don't even see them properly recorded in any studies of peripheral blood mononuclear cells, because when you freeze them, they disappear when you freeze peripheral blood mononuclear cells. So you have to get them fresh, and you have to study them fresh, and oftentimes when they're highly activated, they just disintegrate. They form nets, and it's very difficult to get a handle on them. So I think by understanding the different cell types that are likely the key players in contributing to the disease pathogenesis, we're going to understand how better to target them and suppress them. And maybe by suppressing the key players, we'll also be able to suppress some of the others. So for example, B cells are activated in CTEPH. Pulmonary hypertension is more common in patients who've had splenectomy. So there's something about abnormal B cell function or even B cell deficiency that appears to be important. T cells, people have recognized that a lack of T regulatory cells that control a reconstitution of T regulatory cells can actually improve pulmonary hypertension in experimental models. But none of these cells act in isolation. They all act together. They all live together. They all start off life together. They're in the circulation or they're in the bone marrow niche. So really understanding not only what the individual contributions of these cells are, but actually how they interact, I think is going to give us the best approach to therapy. The most important thing is that when we try an immunomodulatory therapy, we need to really know what we're targeting targeting, we need to measure good biomarkers, and we need to be able to collect samples so that if a question arises later, we can go back to the plasma or the serum and really try and figure out if there was two patients that seemed to be responding, what was different about them and what did we do differently for that group of
And maybe you will identify a common signature to all of those, and you'll be able to apply that to
Right.
more form of pulmonary arterial hypertension as well. So I'll get back to you with a few more questions, Dr. Rabinovich, but I wanted to ask Dr. Zaidi Ali the next question, and it pertains to group 1 PAH in the congenital heart disease subset, in particular the Eisenmenger patient. So we know that accordingly to the French National Registry of PAH, PAH associated to congenital heart disease is the second most common form of PAH, accounting for approximately 28% approximately of cases. And we also know that some form of PAH are more commonly, some forms, of congenital heart disease are more commonly associated to PAH, like the aortopulmonary windows. But one thing that we really don't know is why is the survival and prognosis of patients with PAH and Eisenmenger physiology so different from the prognosis of patients with the other form of PAH. And these slides essentially compare the survival in patients with Eisenmenger physiology derived from the UK cohort of 2006 and the survival of patients with group 1 PAH stratified accordingly to functional class based on the REVEAL registry. And I want to bring the attention of the audience to the x-axis, where you can see it's actually years for the Eisenmenger patient, is months for group 1 PAH. So do you think that we really understand what is the underlying mechanism explaining such a difference in prognosis between the two patient population? And along the same line, as a corollary question, do you think that we should then look more carefully at this patient population to develop novel therapy for PAH, potentially targeting the RV rather than the vasculature?
So thanks, Maria. That's a great question. It's a long question, so I'm gonna try to address it in two parts. So the first part is the prognosis when it comes to let's say complex congenital heart disease and Eisenmenger syndrome, and really taking that cohort and comparing it to the rest of the disease processes. Well, the data tells us that when you have a patient with Eisenmenger syndrome, what happens is not so much, we're focusing on the pH and the vascular remodeling, but it's really what's happening with the RV. Right. And it's really the RV that has remodeled to an extent where it can actually sustain those pressures for a longer period of time. There is some data, both clinical and pathological data, that tells you that those RVs do better in Eisenmenger's patients when you compare it to the non-Eisenmenger's cohort. Now, what's interesting about Eisenmenger or a group 1 PH with congenital heart disease, and again focusing with Eisenmenger's, is two things. One is, if you take Eisenmenger's back, how does the physiology start? Well, it starts when you're a child, as an infant. I mean, this doesn't happen when you're developing at 20, 30. The process starts much earlier. Right. So the remodeling happens much earlier, and the RV adapts accordingly. The second thing that you brought up was how should we be approaching Eisenmenger's syndrome per se? Well, there's that can be answered in two ways too. When you look at drug therapy that's been shown in Eisenmenger syndrome and in PH, there's only one randomized control trial that has been done in the last 20 years looking at any form of PH therapy in Eisenmenger's patients. And that's the BREATHE-5 trial that showed bosentan as the only drug that has shown some benefit in Eisenmenger's. And even that benefit, when you break it down, is really in 6-minute walk tests, and really not much beyond that. So the answer to your question is, should we be paying more attention to the RV and not so much to the pulmonary vasculature? You're right. I mean, I think we just haven't done due diligence when it comes to looking at Eisenmenger syndrome from that standpoint. The third thing with Eisenmenger's, and again, just trying to putting this all together, is I'll put my congenital hat on and say, well, why do you develop Eisenmenger's? You said AP window.
Could be
could be, right? That's
one of the worst, probably.
Absolutely,
right?
That's one of the worst. But Eisenmenger's can come from a plethora of them. It can come from ASDs, it can come from VSDs and whatever. The rapidity of the disease process really comes down to what the lesion is. There are patients who have complex congenital heart disease who live to their, as you just showed, to their
Right.
40s and 50s,
And we have
do
tried to
fine.
replicate that
Yep,
by
right.
creating a shunt, a
That's correct.
palliative procedure, but obviously in the group 1 PAH patient doesn't work equally well. So we
Yeah.
don't obtain the same survival benefit by like creating an Eisenmenger
That's correct.
patient in an adult population
Right.
because we don't have that degree of RB training and remodeling that it's been longstanding in the Eisenmenger patient.
That's correct. And that's just
population.
for the audience and especially the fellows to understand. I think that's the concept, is that the RV just remodels earlier, it remodels differently than it does with sort of other forms of PAH. So which is why I think these patients tend to do better. I don't know if anybody else.
Yeah, go ahead. Anybody else? I mean, I think that's a classical teaching, and we all expect that it is an RV training in a congenital heart. But I'm still wondering if there isn't something else.
Correct.
And we wondered whether, and it struck home because for years I thought, well, maybe whatever's caused the congenital heart defect genetically is also
Yes,
responsible
exactly.
for the pulmonary hypertension. So I thought that, and then we started to culture cells from patients with pulmonary hypertension associated with ventricular septal defects, ductuses, an ASD in our group, and they were all similar. And that as soon as we cultured them after a few passages, they were completely normal, which was distinctly different from cells from patients with idiopathic pulmonary hypertension, whether or not we had identified a BMPR2 mutation or mutation underlying that subgroup. So that made me think that they are different, and that perhaps the way in which pulmonary hypertension develops in that group and is different and allows for some, certainly have the pop-off. So if you repair the patients early, they don't have as good a prognosis as the one, despite the fact that you've still trained the RV to some extent. So there's subtleties even within that group there as to whether or not, so adaptation I think is part of the story. I'm just not sure it's the whole story yet in the congenital heart
So
patient.
I think it's an open area for investigation.
Absolutely.
Which brings me to another question for you, Dr. Rabinovich, and then I'll ask other members of the panel, which is related to access to human tissue, which, as you know, is a major problem in PAH research. And as your colleague Joseph Wu has done in the field of cardiomyopathies, likewise, you have pioneered the use of stem cell technology in PAH. And in these slides, I just wanted to highlight one of your publications on that. In particular, you have derived endothelial cell from IPS that were obtained from carrier of the BMP mutation, which we heard is one of the mutations associated to PAH. And some of those endothelial cells were derived from patients that had the phenotype, and some were derived from patients that were carrier of the mutation but did not have the phenotype. So, what is your impression regarding the utility for the audience of this tool in modeling pulmonary vascular disease? Do you think that has provide the same opportunity as modeling cardiovascular disease for pulmonary disease, essentially?
Right. So it's still a simple system, and NIH was very proactive in trying to get people to work on induced pluripotent stem cells, primarily because they wanted to be able to show that some of the hits that they'd spent a lot of money on in GWAS were actually reflected in a cell-specific manner in dysfunction. So we had all these hits, but since you didn't have a cell to interrogate the particular genetic polymorphism, how would you really know what it meant in terms of function? So they encouraged people to make hepatocytes so you could test polymorphisms that might be manifest in a liver cell, or, in our network there were people making blood cells, macrophages, cardiac cells, of course, cardiomyocytes, and then there were a few of us making endothelial cells, and I was the only lung one, and since the dogma had been that it's a pulmonary specific disease, I did that with trepidation because I figured a generic endothelial cell that was made from a fibroblast was going to have very little relationship to a cell that was in the lung causing pulmonary hypertension. But in fact, they did have a very strong phenotype, and we focused on the patients with the idiopathic disease. And the reason that we looked at at the carriers was because we knew that the iPSCs resembled the native cells that we had harvested from the same patients, we were encouraged to think that we could, in fact, identify differences between the carrier's patient, iPS-derived endothelial cells, and the patient cells, and indeed they were. The carrier cells behaved like normal cells, so the question was why? And we found that the carriers had different ways of compensating for the mutation. When we corrected the mutation in the patient cells, they behaved normally as well. So the mutation was necessary and sufficient necessary for the disease, but it wasn't sufficient if you didn't have those other factors compensating. So there were other compensatory molecules that helped in the signaling of the receptor. So that made us think that if we could improve in some way the signaling of this receptor, like the unaffected mutation carriers did, then maybe that would be a good strategy for treatment, and we've pursued that. The cells have been very valuable as screening tools, and the question is whether or not if you take 7 cells or 10 cells, it's going to reflect the whole population. So I think using these cells together with plasma biomarkers in which you can start subgrouping your patients into different cohorts is going to be very valuable. Now, for APAH, whether it was congenital heart or whether it was drugs and toxins or scleroderma, the cells were not very valuable in that they didn't replicate an abnormal phenotype. So we went back to the drawing board and said, well, then we need to model it better. And so we've been spending a lot of effort now looking at flow disturbance and how that impacts the circulation and whether that's different in certain backgrounds of cells as well. And so I think building more sophisticated models than just monolayer models, but models that are under shear stress. Computer modeling now can give you the shear stress in different vessels at different diameters in the pulmonary circulation, using MRI technologies, but also looking at boundary effects and using computer modeling to get down to vessels that are smaller than 500 microns. So by modeling and applying the same shear stress that you have in a congenital heart defect, I think we'll be better off. And then we need to build onto our system by smooth muscle cells talk to endothelial cells, inflammatory cells talk to them. So really building more complex systems, I think, is going to help us as well. I mean, there's a mutation, caveolin-1, that causes pulmonary hypertension in an animal. You can cure it just by doing a bone marrow transplant. So we look at under the lamppost where the vasculature is, but in fact, there are many other cells that are affected by the mutation that conspire with the vasculature and causing disease, and we need to pay more attention to those. So we're trying to derive now myeloid cells from the iPSCs and study them better as well.
Thank you. That's more to come then. Yes. So the next question is actually for Steve. So Steve, you are an echocardiographer. And as an echocardiographer, I believe you are the first point of contact between the patient, primary care providers, and the PAH center. These slides were taken from the HRS guidelines, and they guide us as to how we can essentially grade the probability of PAH. And we have to take into account 2 factors. One being the regurgitant velocity of the tricuspid jet, and the other being a number of parameters looking at RV size and function. But we know that even if we take all of those into consideration, echo is still not a perfect tool. We might miss patients that have mild form of pulmonary arterial hypertension, and we know that in some group of patients, early institution of treatment might be beneficial in improving outcome. And also we might underestimate the severity of PAH, especially when there is a lot of TR. To add more complexity is the proposed change to the definition of pulmonary arterial hypertension. The recent task force from the 6 World Symposium on Pulmonary Hypertension proposed changing the upper limit of normal from 25 to 21, essentially, and with a PVR of 3. And that is based on the fact that most patients, if you look at the general normal population, the average for the mean PA would be around 14. So soon we will see an abnormal definition of abnormal PAH being hovering around 21 rather than 25. Lastly, which I think is supportive of that, is a recent study published in JACC, looking at the NEDA cohort in Australia, where they actually evaluated patients that presented for a screening echocardiogram. And I think Michael mentioned this study as well, where it seems that patients that had an RVSP between 25 and 35, actually, even though they had, by definition, by echocardiographic definition, low probability of PAH, they still feared worse mortality. So the question to you as a first-line practitioner meeting this patient is, how do you think we can actually better identify the population of patients that is at risk of PAH, and how do we communicate that with the referring physician?
I think this is a very complicated question.
Right.
Part of being an imager is trying to interpret the study that we're looking at in a clinical context. So then I thought that this is what I would say to this question, but many of the echoes that we get are ordered for shortness of breath.
Right.
And so that doesn't really help so much in terms of trying to interpret it in that clinical context. I mean, in general, echo is the gatekeeper to subsequent tests, which Dr. Hadley outlined very well in his monograph that may add some additional information. But roughly broken down into measuring velocities and using those velocities via the modified Bernoulli's equation to get a pressure, and then trying to see the end effects of high pressure on the RV. And that's kind of roughly how we try to figure out what's going on with the pulmonary pressure. The problem is the RV is a complicated structure. It has a complex geometry. It's not quite like the LV, which we're all more comfortable, I would say, with interpreting the function. And so now with this data that you're showing here, registry data from Australia, if we lower the threshold by which we define pulmonary hypertension, the number of people that will have pulmonary hypertension will multiply exponentially. So I think I don't have a good answer for this question, but I think maybe one approach would be to have better lines of communication between the ordering providers and the reader, more than something simple as shortness of breath as the reason why, trying to get a sense for what is the clinical suspicion for pulmonary hypertension on the provider end when we read the echocardiogram, and then being more comfortable maybe recommending further testing if for whatever reason we don't see the TR jet or we can't make it align with our Doppler, referring for other imaging modalities like MRI that might provide other information.
So almost adding a disclaimer to your echo finding where you say, well, this is what we see right now, but if your index of suspicion is high, you might consider repeating an echocardiogram because the test is not perfect. Because I think sometimes that's not perceived on the receiving end. So you do a test and you don't think about repeating the test. So maybe the role of the echocardiographer is going to be more of integrating the information and communicating that to the referring physician. And for us, it's going to be open up the door to a larger population of subjects.
I think so. I mean, our echo lab is fantastic, and we have great readers. But I think part of it is trying to get inside the mind of the person who's being referred and trying to figure that part of it out can be challenging.
Right.
Yeah, can I just add, just wearing my sort of congenital PH hat on, you're absolutely right. I think the onus on echo has always been on the TR velocity. When you look at it, that's really where all the paradigms have been. Look at the TR velocity. If the TR velocity is 2.5 or higher, you're probably going to be moving towards the PH. And anecdotally, it's been debated in multiple forums, as you know, that should the TR velocity in essence be the only criteria that should be defining pH on echo. And I think that's really been sort of debated multiple times. And in some of the things that have been raised over the last maybe 10 or 15 years is should we be looking at other parameters on echo, RA size, for instance, RV, IVC, septal movement. Should all of them be lumped in before we say this is an echo that's going to give you pH? But for this moment in time, you're absolutely right. We're putting all the onus on TR.
Because it's a
It's-
scalable,
yeah.
it's a scalable tool. You can do it in many different
Yeah,
patients easily, and obviously it's going to be the
Right,
first.
and I think those
If I
of us who
can,
do-
if I can just jump in though for a second, I think that most of these patients that you're going to diagnose if you reduce your criteria for pulmonary arterial hypertension are mostly the group 2 patients, right? And those patients are probably going to have a worse prognosis because they've got left ventricular dysfunction, they've got MR, they've got LV diastolic dysfunction, and that's probably what's leading to the increased mortality, not necessarily increased pulmonary vascular tone. And I think that's probably what you're picking up, as I learned here, again, that group 2 is the most common etiology for pulmonary hypertension. That's the group that you're probably picking up and is a marker for increased mortality. And I don't know that necessarily focusing on, we can focus on that as a marker for left-sided disease, but it's not necessarily that by treating pulmonary hypertension that we're going to get those patients better.
No, exactly. I mean, this is a combination of all comers. So it includes most likely a lot of group 2, but also will include some group 1, group 5, and other patients. So I think, go ahead, Dr. Rabinovich.
Could I ask Steve a question? What do you think of the, and full disclosure, I'm on the paper, Miriam, although I was just a cheerleader, honestly, I don't do echoes. But she described 2 parameters, basically looking at diameter approaches, and it looked pretty good and gets away from some of the problems with velocity measurements when you can't measure them very well or you've got differences in cardiac output as a very simple tool for telling us that RV was under some sort of a shear stress or strain.
Yeah, I mean, I think, I think it's intriguing. I guess what I would say as someone who kind of reads the studies on a day-to-day basis is that the study quality on echo, even though our texts are really great, is highly variable and sometimes quite patient-dependent. So I think having as many different tools and measurements that are available to us, like measuring the PR regurgitation, velocities, simplified measurements, looking at the shape of the RVOT pulse wave. I mean, these are all things that we know, but the trouble again is, do we make and report all these measurements on the 1,000 echoes that we read in a month or whatever the case might be, or might it be better to target the text and the attendings times for patients that maybe have a little bit of a higher clinical pretest probability going into the study? I think that might make things a little bit more practically possible to kind of find these patients that way.
Right.
Because to
many
Maria
ways,
and Barry's point, this is a symptom of something else. It's almost like a biomarker when
Right,
you look at that,
exactly.
right? Is what you're saying. It's telling you there's something else that is manifest as a slight increase in pulmonary pressure, but isn't pulmonary hypertension as we know it. It could be metabolic syndrome. It could be systemic vascular disease that is also affecting the pulmonary circulation. There are many things
different
that can
things, yes.
contribute LV.
But it definitely, we don't have to think about RBSP of like 35 as being normal and everything else, abnormal and everything else to be normal. So I think we have to increase our index of suspicion that patients that don't have an RBSP of 35 are really like doing great, because it can be misleading for the referring physician. So the next question is for Barry, and it is regarding the topic of treating to close. So this slide essentially is the classification of congenital systemic to pulmonary shunt associated to pulmonary arterial hypertension. As some of you might know, we have 4 different groups. Group 1 includes the patient with Eisenmenger physiology. Group B includes patients that have primarily a systemic to pulmonary shunt, where we would consider closing, so treating to close with the intent to close. Group C are patients with PAH and small defect, where essentially the degree of pulmonary arterial hypertension that we see is out of proportion in comparison to the severity of the defect. And then Group D patients are the patients where we have closed the defect and yet they develop pulmonary arterial hypertension. And we do believe that the reason why that happens is because we have intervened too late in the course of the disease. So the concern, obviously, in this approach treating to close is to convert a patient who is Group C into a Group D patient, because we also know that patients that are Group D have a worse prognosis than patients that are Group C. So I'll run through a case for you, which you have actually cut this person. a 54-year-old woman with progressive shortness of breath, fatigue, and exertional cyanosis. She undergoes an initial echocardiogram that shows the presence of a large ASD, and then eventually a cardiac MRI that shows that there was significant RV dysfunction and evidence of RV volume and pressure overload, and a large secundum ASD measuring 2.8 by 3 centimeter. She undergoes right arc catheterization. Actually, you performed the right arc cath. I was wondering whether you could walk us through this right arc cath, which obviously shows significant PAH, if you can see it, and tell us whether or not, on the basis of the information that I gave you, you would consider this a patient where you would attempt the approach of treating to close. So she obviously has a significantly elevated mean PA pressure to 62. She has a low wedge, left and right of 4. She does have evidence of a differential pulmonary venous saturation, and she does have significantly elevated PVR. And you did the measurement on 5 liter and also on 100% no rebreather to look for some degree of vasoreactivity. So is your impression, I'm not sure you remember this case, but I was wondering whether on the basis of this information, the size of the defect and the degree of pulmonary arterial hypertension, you would think of this as a case belonging to Group B, where you would consider closure.
Okay, it's a tough one. So I remember distinctly this patient and saying, well, let's treat for a little bit and we'll kick the can down the road and recath, because I don't think I really knew what was going on at the time. I was impressed by the fact that this patient actually came in with a systemic hypertensive crisis, actually, and was very hypertensive at the time. What's interesting is how much left to right shunt this patient had, despite the pulmonary hypertension. So that was kind of curious, and the fact that there was significant pulmonary venous desaturation that was accounting for her desaturation, and it's difficult. It's actually impossible to tell how much is right to left shunt versus how much is pulmonary venous desaturation, because once you've got pulmonary venous desaturation, you can't tell how much is going right to left. You can't tell how much the desaturation is coming from the pulmonary venous desaturation versus how much is coming from right to left shunt. But the fact that there's a net left to right shunt of almost 2 to 1 is somewhat encouraging, that if you could eliminate that shunt, that you may actually decrease the pressure in that patient. Now, whether that actually leads to prolongation of life, decrease of symptoms, I think is very difficult. I think this concept of treating treating to close or treating to then make to candidacy, I think is difficult. I think in a lot of instances it's optimistic. We know how bad the prognosis is if they aren't treated and they're doing poorly. So the idea is, well, can we move them into a group that we think is better? And I don't think that that's been definitively shown. Most of the people that have reported these, it's very short-term reports. So I've had patients, for instance, that were treated for pulmonary hypertension, for instance, with a ductus arteriosus, and then had the ductus arteriosus closed and came to us a couple years later in severe right heart failure, and the patient was dying, and we didn't really have much to do for that. We fenestrated the ASD and whatnot, and the patient ended up dying a terrible death.
It's difficult to know whether their prognosis would have been necessarily different.
Correct. But that patient actually had for example, just that one patient with the ductus actually had a pop off and was doing okay before that, so far as I could tell. So I think it's difficult to know. I think in a lot of instances we're trying to be optimistic. This particular patient I think is interesting, and I think that it'll be interesting to see when we recatheterize her how she's doing. See if she had a lot of fluid overload and such, if her pulmonary venous desaturation has improved, if her saturation has improved, and if we really still have a significant left to right shunt, it may be useful. There have been some techniques for closing them where you can actually fenestrate a device.
Right.
You wouldn't want to close this we would hope to be able to close this with a device, because surgically the problem is that the pulmonary hypertension that can arise from cardiopulmonary bypass can be life-threatening, and you may not be able to get them off the pump and these sorts of things. So if you could close it with a device and fenestrate it, that would be interesting. So all of these things are interesting. I just want to add an aside. I'm sure that Dr. Rabinovich doesn't remember, but I was a pediatric resident doing an elective at Sick Kids when Dr. Rabinovich was the consult attending. Angie Yetman was the fellow, and I was the resident. And one of the things that got me interested was, I was already interested in cardiology, but one of the things that kept me interested in cardiology was Dr. Rabinovich's tutelage. And I'll just say that year was 1994. It seems like a long time ago, but I remember it distinctly because that was the first year I went to the American Academy of Pediatrics meeting, and everybody was very excited because the journal Cell was touting this new discovered molecule called nitric oxide that was touted as the molecule of the year. So we've come a long way since then, but it was certainly an exciting time then, and continues to be an exciting time.
Thank you. That's great. Do you want to add something, Dr.
I'll wait
Rabinovich,
for
or-
No, it's great to know. Did you remember anything from what I did? And one of my former fellows was actually conferencing with us from Cedars in LA, and he asked if I was in the audience because you remember I had taught him something about pulmonary venous hypertension. So what's the etiology of the desaturation?
In this patient?
Yeah.
Honestly, I don't know. She came in, I think she was quite fluid. She was quite fluid overloaded when she came in. She actually came in, she was transferred with a systemic hypertensive crisis, and I think a lot of that had to do with then fluid retention and such. So it was on a lot of oxygen and such, and had gotten a lot of diuresis already, and was actually substantially better when I catheterized her than she had been, but clearly not fixed yet.
Although to play devil's advocate, her wedge was really low, was like 4. So
She might have a parenchymal process. I mean, it
Yes.
might not have been all left side. It might have been
Right,
parenchymal.
it
But
might have been something
it's
else, yeah.
so can I make a comment on this? By the way, this is pretty cool that Dr. Goma, you have 3 pediatric cardiologists on the panel. So
Yes.
it's essential. I think so. Just a thought about treat to close. Just again wearing my congenital heart disease PH hat on. This has been debated again for a
Right,
while
yes.
as to how do we get patients who have a shunt lesion, who have PH, and
Right.
get them to a situation where we can close them. It's fascinating data. When you look at the data, there's only, I want to say, maybe 3 or 4 published papers on treat
that.
to close. And the largest registry data just got published about a month ago with 79 patients, adult congenital patients who had some sort of a shunt, who were treated and then closed. And it's fascinating data because when you look at it, it was a retrospective registry across 12 large centers, and every center was doing it differently. Every center was doing it differently. Someone was using a PD5, someone was using an ERA, someone was using prostacyclin, someone did single agent, someone did double agent, but they closed 79 patients after treating them. And they had, that study actually showed great results in the sense that it was only 1 year post-closure data, so it's still short-term data.
And was there any difference between the
So
different
3
groups?
things changed. 6-minute walk changed, it got better, which you would assume. The RV size and function got better. And obviously the PA pressures were getting better. So they were all closed, these 79 patients. The reason I'm saying this is because that one study is the only one that has 79 patients. If you look at the plethora of PH data out there, only one large study with only 79 patients. So this is still being debated.
Comment?
Yes.
Sorry to comment, but we published the first paper
Yeah.
in the Mayo Clinic, and you know about it.
Yes.
70 patients with ASD in pulmonary hypertension, and in fact, a pulmonary vascular resistance index of more than 14 units meant death with surgery. Let me tell you what happened. The deaths were happening about 14 or 15 of these patients. Half was at the time of operation because with anesthesia, there's vasoconstriction, and the right ventricle is not able to pump.
That's right.
But there's something else. The disease progresses after surgery.
Yes.
Right.
And that is, there is another mortality that may happen in the first year post-op that is because of the progression of the disease. So in fact, at Mayo, I can tell you a pulmonary vascular resistance index of 14 units or more, no surgery is considered, regardless of the shunt in anyone.
So again, for the fellows, this is something important to grasp, is that you're looking at a lesion that's giving you a PVR that's high. The study that I just quoted had a mean PVR of 7, PVR as 7 or 8, versus the 14 that Dr. Fuster is saying.
Right.
So again, this has been debated for a long time.
Is there an attempt to create a
So
multi-center,
fantastic question. Yes.
Group
Yeah,
to study that?
Yeah, so the next step forward, only because I was part of the registry, I know this data pretty well, is that we're actually taking it forward and we're trying to take it to an N of maybe 200-300 patients and see where we're at. In fact, in Toronto, there is a pretty substantial number of patients that have been treated and closed. But that data hasn't, I mean, some of it has been published from what I recall. But yes, you're absolutely right. The idea is, can we take this cohort, treat it, close it, but follow them long-term? Because as Barry and as Dr. Fuster said, what will happen to them long-term, we don't know. All the data is short-term.
But standardization is required,
Absolutely.
essentially.
It's fascinating, absolutely.
Yes.
Yeah.
Yeah, and the ones that do well, I agree, don't have a PVR of 14. This patient didn't either and has pulmonary venous desaturation, so you really don't know where you are. But the left to right shunt is pretty impressive. I mean, my former chief, Dr. Natus, used to say the only thing you could trust on a cath report was the birth date, you know? Which is helpful because the younger children always did better than the older ones, no matter what their PVR was. So, and the next thing was the PA saturation, obviously. If there was a big step up, you could feel comfortable about that, the next numbers. But after that, when you get to PVR, you're in murkier water unless it's really very high or very low. So I think the fact that you had that confounding variable makes you have to take another look. I think that, and the Toronto group, they asked me to look at biopsies of the patients, and they kind of all looked like they had pulmonary vascular disease, but the net left to right shunt, and Dr. Cohen was actually in Boston was actually proposing that we close more of them. And so Bill Williams did a series, and they did very well. And a number of them haven't been recast, so we really don't know ultimately where they are, but they're living.
Yeah, going back to your point, I mean, this is fascinating dynamic data that's out there. And I think the way to do this going forward is not just do the clinical arm of this, but actually go to the bench, get biopsies, and then see where you're at and follow them down the road.
Whether you can have some other pathological biomarker that you can use to re-stratify essentially beside the invasive hemodynamics. So, and the next question is for Michael. Oh, sorry, did you want to add something else?
Yeah, and I had another comment. You know, it was interesting. The other thing is pressure offloading and what that does ultimately. If you can reduce the pressure, I think it has a profound effect. So a number of animal models we used where we took a lung from a diseased animal, put it into a normal animal, and showed that the vascular disease regressed. And that came at a time when Jesse Edwards had described, who Dr. Fuster knew well, patients that had a single lung transplant, and when they developed bronchiolitis obliterans in the lung transplant, and they had Eisenmenger's, and he went back to the lung that hadn't been transplanted, and he had the tissue from the other lung that was taken out. He said the vascular disease had disappeared. So the question was always, was it just the pressure offloading, or was it actually the fact that they were on drugs or immunosuppressives, and that may have had an effect in view of the work that we're doing now with FK and other agents. You think about it a little bit harder. So there have been studies now where they've created, Dr. Rolf Berger has done them in Leiden, where they created a left-to-right shunt with an AP, basically an AP window, and also gave the animals a toxin, and they developed severe pulmonary hypertension, and then at various times what they did was transplant the lung. So after 7 days, everything regressed. After 14 days, everything regressed. After 21 days, well, half the animals got better, half didn't. And after 28 days, none of the animals got any better. So the point was that it was pressure offloading up to a point. But then my point was, well, that's true, except maybe we don't know how to decrease. Maybe it's not enough, and to say they're irreversible isn't good enough. So I said what they did a whole bunch of RNA sequencing and found that the cells had gone into more of a senescent phenotype. When they do that, they produce a lot of cytokines. So they started to treat them with agents that reverse senescence that are used therapeutically now, and the animals got better. So what you say is irreversible one day may not be irreversible down the line.
Exactly.
I think we have to keep thinking that way and pushing the envelope.
Thank you so much for this is great discussion. And Michael, I have a question for you pertaining to group 2 PAH, which, as you said correctly, is the most common form of pulmonary arterial hypertension, yet we don't have dedicated specific therapy targeting this form of pulmonary arterial hypertension. Around the same time, Robin Burrs published a paper in the New England Journal on the use of epoprostenol in group 1 PAH. There was also this study that was published, which unfortunately had the opposite result. It's the first and the last, unfortunately, to be conducted in this group of patients with the advanced left ventricular dysfunction, and it showed that patients on Flolan did worse than patients that were on conventional therapy. We also know that within the group, and you mentioned that already, that have group 2 PAH, there is essentially two groups that we need to identify. One is the group of patients that have the passive form of PAH, and the other one, the group of patients that have out of proportion to PAH, where there is a combination of arterial remodeling and venous pulmonary arterial hypertension. So I wanted to ask you, as a fellow, when you see a patient with pulmonary arterial hypertension and you have the information on the right heart cath, you know it's a group 2 PAH, what is your approach to essentially diagnose and manage this patient? And if you can touch upon some of the studies that you have read looking specifically at this cohort of subject.
Sure. So I guess the crux of the issue is this distinction between the purely post-capillary pulmonary hypertension and the combined phenotype. So determining that's going to affect my management.
Right.
Regardless, you're going to start with basic non-specific therapies for heart failure, diuresis, neurohormonal antagonism, to try and optimize the left ventricle,
Right.
Reduce those pressures, and maybe reduce the wedge pressure, reduce backflow through the pulmonary circulation. If after that the right heart cath still shows an elevation in pulmonary capillary wedge pressure and a transpulmonary gradient or a diastolic pressure gradient that's elevated, and that suggests that there is some pathology in the pulmonary circulation on top of the left ventricular dysfunction. And when you look at the histopathology of those patients, you see some changes, vascular proliferation and stuff, similar to PAH. So those patients may potentially benefit from therapy, from PAH-targeted therapies. The study that you're referring to, I think, lumped a lot of these different heart failure
Yes.
patients together, right? It was kind of non-selective, and this isn't the only study that did that. There was, I think it was on the sildenafil and some others as well, the diastolic, systolic. They didn't stratify based on these different subtypes. Which is probably why they got a negative result. There were some smaller studies earlier on sildenafil that showed a positive result. So the question now, I think, is if we look specifically at patients with the combined phenotype,
Right.
and only that phenotype, can we see an improvement through these three pathways that are classically used to treat PAH? And so you asked what studies. So there's the Southpaw trial currently, which I think is looking at treprostinil, which is a prostacyclin analog versus placebo in heart failure with preserved ejection fraction and combined pre- and post-capillary pH on right heart catheterization. So that'd be interesting. I don't think we have the results from that yet, but it may show that those patients would benefit. And then I think there's also riociguat's also being evaluated.
Right. Yeah, you're right. There are a number of studies, including the one that you mentioned, and some evaluating the use of macitentan, oral riociguat, and even oral treprostinil, and oral tadalafil as well. But I think the jury is still out there. We yet don't know exactly what to do with this group of patients. But it remained the largest cohort of pulmonary arterial hypertension. Definitely a different phenotype than group 1, but worthy of being investigated. And Uman, I have a last question for you pertaining to group 3 PAH. You've talked about out of proportion to group 2 PAH when we have a combination of arterial and venous pulmonary arterial hypertension. We also use this definition of out of proportion to group 3 PAH in some subject when we have essentially an hybrid combination of COPD, emphysema, lung disease, but also arterial remodeling. I wanted to get your opinion about how you would approach this particular case and what are the elements that you would use to make a decision as to whether or not the patient has group 3 PAH, for which, as Michael said, there is no dedicated therapy available or FDA approved, and those that have out of proportion to group 3 PAH, where you would consider some vasodilatory agent. So this patient was a 71-year-old female with history of HCV, was treated with Arboni treatment, had hypertension, diabetes, COPD, obviously many risk factors for group 1, group 2, and group 3 PAH. And was complaining of worsening shortness of breath. She has an echocardiogram that shows an elevated RVSP, and ultimately she undergoes right heart catheterization that reveals that she has a significantly elevated mean PA pressure to 36. I'll point it out for you, with preserved right-sided filling pressure and a low wedge. She also undergoes further investigation of her lung parenchyma and lung function with a CAT scan that shows that she has moderate degree of emphysema. Her FPV1 was approximately 60%. Her FVC was, I believe, 71%. So it would be great if you could walk us through the process or the information that you would need to determine whether this is really a combination of group 3 and group 1 or in isolation group 3 PAH patient. And if you decide to treat, what would be the treatment of choice in this patient population?
Yeah, so this is a very common problem that we encounter. And I guess the first question is, how does lung disease cause pulmonary hypertension, patients with COPD and ILD? And it's, multifactorial and kind of unclear. If you take patients with severe COPD, for example, like in the NET trial when they did lung volume reduction surgery, everyone got cath, and every single patient had some mild degree of PH. But that doesn't necessarily mean that their symptoms are limited because of pulmonary vascular disease. It may just kind of be a sideshow or an effect of the lung disease. On the other hand, you have some patients who have mild COPD that have severe pulmonary hypertension, severe RV failure, and would we call that someone who has PH secondary to COPD, or do they have COPD and concomitant, quote unquote, group 1 PH? It's hard to say. So at the end of the day, a patient like this, you basically want to assess their lung disease and you want to assess their pulmonary vascular disease separately, partly because pulmonary vasodilators, in essence, will worsen gas exchange. Michael mentioned that your lungs are smart and they only want to perfuse areas of the lungs that are well ventilated. When you give a vasodilator systemically administered, you now open up those areas and worsen VQ mismatch. So someone who is severely compromised on a lot of oxygen with poor VQ matching, you give them a vasodilator, they'll become more hypoxemic. On the other hand, that may improve their hemodynamics. So you have to ask the question, which one is worse, the lung disease or the pulmonary vascular disease? So someone who has a CAT scan that looks like this with a low FEV1 and maybe normal RV function and only mildly elevated PA pressures, a pulmonary vasodilator will almost definitely make them worse. Someone who has a mild decrease in their FEV1 on no oxygen with severe RV dysfunction and decreased cardiac output, the decrement in gas exchange may be outweighed by the improvements in cardiac function.
Although histologically, correct me if I'm wrong, like in COPD, it's more of similar to a post-capillary form of PAH, right? In terms of arterial, like process of venous remodeling, it's like closer to group 2 than it is to group 1, right? So I'm not sure that I know we say that it's related to essentially perfusion of areas that are not ventilated, but I'm not sure how we can correlate that histologically with the finding that is more of post-capillary finding on the histology. That's what I seem to remember.
I mean, for COPD at least, it's multifactorial. Again, there's numerous different mechanisms. There's inflammatory process. I mean, you could also tell me a lot more about this. But inflammatory processes in terms of in arterial remodeling. There's also just with alveolar distension, you can get capillary compression, which can result in precapillary issues as well. And a lot of patients with COPD have concomitant left heart disease, which you have to be careful about, and having a post-capillary issue as well. So it's unclear, and then why these patients have that.
Yeah, I mean, if you lose airspace, you lose arteries, and arteries also regulate airspace development in the newborn. So I think part of it is the rarefaction of the circulation when you have severe emphysema. The other part is obviously the inflammatory component. So we talked about neutrophils and neutrophil elastase, and it was shown recently, in fact it's a Cell paper, that if you aspirate patients with COPD, you can measure exosomes or extra cellular vesicles that are produced that are just laden with elastase, and for some reason alpha-1 antitrypsin doesn't block them very well. So, and then you take those those particles and you put them into an animal, and the animal develops emphysema, not surprisingly. So the inflammatory component is certainly, it comes and goes, but it's certainly part of the process, and that's not good for the blood vessels either.
Right.
The venous changes, when you see them, I think are more related to some left heart component than the arterial. The arterial's never as bad as it is in primary, and usually the patients are responsive if you can treat their lung disease, but that's the biggest problem I think that you're facing. But if you lose airspace, you're going to lose vessels.
Yeah,
And you're maximally recruited under those conditions as well as you can be.
And I mean, one of the common pathways always, in these patients with lung disease is when they develop PH, their mortality goes up, dramatically. But that doesn't necessarily mean treating them with pulmonary vasodilators improves outcomes. But it does mean that they need to be, referred to lung transplant and so on.
Thank you. I'm not sure we should ask some question from the audience if anybody's. Then if there is still some time, I have an additional question for Dr. Rabinovich, which is related to the fact that, for example, for the BMP carrier, I mean, the mutation is present in all the cells of the body, yet the disease manifests primarily in the vasculature of the lung. Is it that really true, or now I believe there is mounting evidence that actually it's not an isolated process in the lung vasculature, although it's predominantly in the lung vasculature?
Right. So it is interesting that the more you look, the more you find evidence of other systemic vascular disease. So my colleague Sebastian Bonnet, for example, took muscle biopsies and said, is some of the problems with fatigue and exercise intolerance not due to the pH, but due to basically a vasculopathy in skeletal muscle, and did find it. And since then, there have been a number of studies suggesting that systemic vessels are also affected, but not to the same degree. So for example, patients with severe pulmonary hypertension that have a BMPR2 mutation don't have flaming arteriosclerosis or premature coronary artery disease. And the question is why? Because when you take an animal that has a knockout of the LDL receptor and you cross that animal, Dr. Joe did that at Emory, with an animal that lacks BMPR2, even a heterozygous animal that doesn't have disease of its own, the atherosclerosis gets a lot worse. So the question is, if it does have implication, and we grew iPSCs and they have a phenotype, they don't form vessels normally, they don't regenerate vessels normally, so why don't we see more systemic vascular disease or more severe systemic vascular disease? And there must be another component of systemic vascular disease, whether it's hypertension or atherosclerosis, that's just not there, so it's not sufficient. But that also makes me think that we should be looking for BMPR2 polymorphisms and factors that regulate BMPR2 in patients that do have atherosclerosis and systemic vascular disease, because there may be a component of their disease that is also related to this genetic abnormality, and that also may, in fact, need to be treated differently.
Thank you. That is great. So if no one has any question, I'd be pleased to close the panel, and thank you all the members of the panel for having contributed to a very interesting discussion, and obviously to Dr. Rabinovich.